morning, everyone. Hi, I'm James Chiang, one of the second-year residents from the University of Central Florida. And I'm very pleased and privileged to be here to be talking to you about dual sequential defibrillation, what you should know about it. And hopefully, the goal of this talk is so that more people will be aware of it, try to use it, and encourage some future studies. All right, so imagine you're in the last 30 minutes of your shift and you hear the EMS radio call for a 60-year-old male with witnessed cardiac arrest. Bystanders started CPR, and EMS placed the king tube, and CPR is ongoing, and total downtime is 10 minutes. And the initial rhythm was VFib, and so the EMS shocked him once and gave epinephrine. Rhythm check in the ED is still VFib, so you shocked him second time, gave amiodarone. And the third rhythm check is still VFib, so you give him the third shock and another epinephrine. And in the meanwhile, you're going through your H's and T's and thinking about what else to do, starting to throw the kitchen sink at him. And another option that you can consider at this point is dual sequential defibrillation, or just dual defib from now on. It is the near simultaneous defibrillation from two defibrillators with two sets of pads placed side by side in the anterolateral position, or the second set of pads in the anterior posterior position. And its indication is refractory VFib. And so it's pretty loosely defined as persistent VFib after 3 defibrillation attempts, plus minus amiodarone. And there are several proposed theories for why dual defib is effective. The first theory is the vector theory. And so by having 2 different vectors going in at different, 2 shocks at different angles, you increase the chance that it is aligned with the correct vector for defibrillation. And there's also improved distribution of currents through more cardiomyocytes. And the second theory is the timing theory. And it's based on canine models that show that having 2 defibrillations in rapid succession about 100 milliseconds apart requires a lower voltage than a single shock, likely because the first shock lowers the defibrillation threshold. Finally is the total energy theory. And we know that patients with higher BMI require higher voltage. And in refractory VFib, our standard defibrillation may not be sufficient. And 2 machines together may overcome the electrical storm. And also there's some evidence to suggest that using S-molar bolus and drip in refractory VFib helps to achieve and maintain ROSC, likely by counteracting excess catecholamines from epinephrine and also by increasing the fibrillation threshold. And there are several case reports and case series in favor of dual defib. As you can see, there's remarkable conversion rates and survival at discharge with good neurological outcomes. However, recent larger studies don't seem to agree. And there are 4 large retrospective studies I'm going over, and their conclusion is that dual defib does not improve ROSC. It also does not seem to improve outcomes. 2 studies even show that it's associated with lower ROSC rates. So could dual defib be doing more harm than good? After all, there has been 1 case report of a damaged circuit board in a defibrillator after it was used with 2 machines of different brands. And so, now what? Well, so there's some limitations to these larger studies which the authors recognize. And so, without discrediting their incredible work, we're going to go on a very deep dive to see what some of these limitations are. Are you guys ready? Attention span of 3 minutes. Are you guys ready? Okay, good. All right. So, in the first study that we're looking at, the ROS study, the dual defib group had fewer witness arrests and bystander CPR. So, even with less early CPR, the dual defib group did not do worse. In the second study, the Emerson Study, the average number of standard defibrillations before trying dual defib is 10. So, it selects for the extremely refractory cases of VFib, and the benefit of timely dual defib will be less apparent. And they also had fewer witness arrests as well. In the Beck study, the dual defib group was resuscitated much more aggressively. They received more epinephrine, amiodarone, and total number of defibrillations, and they had lower ROS rates. So likely, their sicker patients received dual defibrillation. Now, the MAP study uses the same data set as the ROS study, and the dual defib group still had lower early CPR rates. Also, the the dual defib was done usually after the 4th or after the 5th shock. And so again, it's selecting for more refractory cases. And we know early CPR and early defibrillation together increase survival. And that's why the large study authors, they also mentioned that the dual defib do need to be earlier. I couldn't find timing details from those large studies, but we can look at the figures from our case series. So the patients with good neurological outcomes are highlighted in red. And as you can see, they receive the intervention sooner. And it makes sense because the longer the code runs, any intervention is less likely to make a difference. And it's 5 minutes? Okay. Thank you. So, I guess the time included the first slide, huh? The time included the first slide.
Yeah, but I mean, you did. Seems like you ended just about right. Dr. Chiang, just the judges have a little bit of feedback for you while I load the next presentation. Dr. Xu, you can come on up.
So great job. Good job presenting. Your slides were good. Just the timing was the thing. I think that might have gotten you a little bit.
Yeah, I didn't realize the first slide was part of the time, too.
That's all right. Very good. Thank you, everyone.